Hello guys, I'm so excited that finally I have just received my new book, The Bible of Bodybuilding. It's a book that consists of 400 pages. You can purchase this book on Amazon, and this book contains my former books, The PDs Used in Sports and The Good, the Bad, and the Ugly, plus the Training, Nutrition, Supplementation, but also including extra features, Q&As about gear, about HRT, but also a quiz regarding supplements, diet, and of course PEDs. So the Bible of Bodybuilding on Amazon, both on ebook and Kindle version.
Hey everybody, welcome to Ask Dr. Testosterone, starring Dr. George Choulianos. And today we have a very special two very special guests. We have Andre Miller, owner of Frontline Alternative Medicine, and with him is Dawn Thornhill, nurse practitioner, IFBB professional, and clinical supervisor for Frontline. Welcome to the show, guys.
Hey, thanks for having us.
Thank you.
Hello, Andre, and hello, Dawn. It's my pleasure meeting you again online. Now, Andre was the main sponsor of the adult educational, and through Dominated Game, it was the guy who was able to give birth again to this educational lecture series, because we had a tough period after COVID, and it was a surprise having also Dawn as a nurse practitioner to be part of the panel, and we had an excellent discussion with Rick Collins and Eric Serrano as well in the round table. And I had to invite you over here because I want to show my gratitude, because I was part also of this educational series. And Lacey and Michael also embraced me and being part of our educational family. So welcome aboard and be one of my guests. And we know that we support the testosterone culture. We are people open-minded. We are against the prejudice and the skepticism of the medical society that is closed-minded to the benefits, to the plethora of the good things that testosterone does. And actually today in my office, I had a gynecologist who came far from an island, Greek island, telling me, Doc, I feel lousy and I need some testosterone. So he started self-medicating with Nebido. And I told him that, of course, this is an old-fashioned protocol, but I was very optimistic, and I was very enthusiastic by the fact that a middle-aged, he was 45 and he was looking, I have to tell you, 5 years older at least. He was hypogonadal, and it's very promising the fact that he wanted to start using testosterone. He was concerned a little bit for fertility, but this is, of course, resolved by ACG, but it's very promising day by day or week by week or month by month or year by year that the medical society starts to open up and accept the benefits of the testosterone. And actually being out of testosterone is way more critical than the few side effects that can be managed through the testosterone use. So I know that also Ron is into replacement therapy, of course. He's been also, yes, as a steroid user, he was a Morgan Taylor patient initially. And I've been also reviewing his labs once upon a time, And yes, we can discuss about a little bit of the implementation of replacement therapy, because everything starts from the States. This is the land that spreads the knowledge to Europe.
I want to ask Andre, how did this company come to be? What's your background and how did you put Frontline together?
Well, you know what? I was that guy that couldn't get treated. I found a clinic that would finally, I got diagnosed when I was 27. My testosterone was at a 280. I couldn't find anybody who would treat me with anything other than androgel. So I went on to be miserable for another 10 years. Found a doctor that would treat me, started my testosterone replacement therapy with just testosterone, nothing else. I called to get a refill one day and his office was closed. I'll try to keep it short and sweet. Then I jumped online and started researching testosterone replacement therapy groups on Facebook. I found a clinic called Entourage and started with them. That was where I began my treatment. I saw in that group that I was in that there was a lot of need for communication. I was seeing a lot of people that were going without being reached out to for treatment. And so I reached out to the Henrys and said, hey, I'd love to be a part of your company. Let me know what I could do. They sent me some information, and started there, and I just started developing rapport with the community online. Worked for them for a little under a year, and things kind of fell apart, for whatever reason. And then I went on to partner with another clinic, Viking Alternative Medicine, and we just didn't see eye to eye on the way that we wanted to run our businesses. So I broke away from there and was given the opportunity to start my own clinic, and I could do things the way I wanted to do them, because I wanted to have a program that we hold dear to us called our Frontline Hero Foundation, or a program where we treat veterans and first responders that are in financial crisis for free.
Wow. Very commendable. Very commendable.
We try to take on as many as we can. We can't take on the world, but we have started a Frontline Heroes Foundation that's gonna take over that. And we picked up a couple of big donors.
Yeah. George, what is in Europe, what's the TRT situation? How hard is it for men to get prescribed TRT over there versus
yeah,
USA?
So I'm also cooperating with the UK. I'm a medical director of the Balance My Hormones, and over there they're telling me this online clinic that we work with patients throughout Europe, that they found a really negativity from the NHS and the endocrinologists and the urologists, that you have to be really low, considerably dead, in order to prescribe you testosterone, and they leave you in this lousy misery, and they prescribe you alternative things that, like the vasodilation drugs, the phosphodiesterase inhibitors, that obviously they don't resolve the problem for where it starts. And they have this negative propaganda about the testosterone that of course comes out of the abuse, but they believe that testosterone is a villain. It's still a steroid, where actually it's an androgen that you cannot live without it. And but the past 5 years in Greece, I've been working with a clinic. They wanted me to give my know-how and my knowledge regarding the replacement therapy with testosterone in guys. And I have to tell you, they were really backwards. They had no knowledge about the HCG, the Proviron. They were just using testosterone cream. And they had no idea about the microdosing with the injections, But I have to tell you personally, I have put a lot of people, a lot of men, between 50 and 100 men for the past 5 years into testosterone. Some of them were doctors. Okay, it was a case of a heart surgeon who had a heart attack out of low testosterone, and he came to me, a Harvard graduate, and he told me, I had a heart attack due to low testosterone hypogonadism, because low testosterone is linked to cardiovascular disease. And the doctor told me, I need testosterone in order to optimize my cardiovascular health, So it was really impressive and really enthusiastic and promising, this thing. But I have to tell you that, yes, I have perhaps this kind of monopoly out of the endos and the urologists, that I'm dealing this guy with testosterone, with men having testosterone issues. Anything, yes. Another thing is that I'll talk in a congress of psychiatry next summer, speaking about the benefits of the testosterone in the mental sphere. Okay, so how it affects the mood and the positive thinking of the testosterone user. So I believe that the medical society embraces gradually the fact that being low in testosterone is not something healthy, But it takes time, because Europe is a little bit backwards, of course. And we take the knowledge from the West, from the States, where TRT is already known for a decade, at least,
Yeah, Andre, I think we've made great strides in awareness and the need for testosterone replacement therapy and the benefits it can have, but I still think we have a ways to go. And I think part of that in our culture is we've had this backlash against quote unquote toxic masculinity, and anything that makes men more manly or masculine is looked down upon by a large group of our society, or at least a very loud and vocal group, I should say. So what would you rate, Andre, as the situation in the USA right now? How far have we come, and how far do we still have to go?
I would probably say we're about halfway.
We're starting to get some mainstream talk about TRT and the benefits. Some of the podcasts, Joe Rogan, multimillionaire, very well known, very vocal about how TRT has changed his life and helped optimize his health. So I think that helps, that people are starting, that the younger generations, as they've come up through the, as they come up, they start to recognize people that they admire, athletes, MMA athletes, who are acknowledging that, I was deficient, and the way that I'm able to perform and feel well and keep my peak performance and my body in the best shape is because I optimize those hormones because I was deficient. And so there's starting to be a little bit more mainstream talk about it.
And our main focus has always been the everyday average Joe, the guy that never wanted to be, or once was, helping them, get back to where they feel like a man again, where they feel like not like they can take over the world, but like they can be more productive members of society, where they're not just going home, sitting on the couch and not doing anything, kind of like me, I went home from work and sat on the couch and didn't do anything. And once I got everything balanced out, I've, started 3 different companies, and it goes back to, I didn't understand why my peers had more drive than I did. And as soon as I felt that change, I knew what was missing my whole life.
I want to ask Andre, if somebody shows up in your clinic and says, listen, I need TRT because I want to get jacked, or improve my body dysmorphia or my body composition, even though he's not hypogonadic, have you denied access to replacement therapy? And also, if you have faced any issues and negativity out of the medical system and endos and urologists mainly, that believe the private clinics overprescribe without the need of testosterone if you're not officially hypogonadic.
So the beautiful thing is that I let Dawn make all those calls. I don't get involved. I give her the power to make those decisions. And honestly, that's her job. My job is just to do the marketing and advertising. So I'll let Dawn tell you about that.
So
Okay.
sure, we definitely have the patients who do their lab work and they will vocalize in their intake paperwork. I know before I even have that first moment to talk with the patient that their intent is to improve their physique. They have a section in our intake paperwork where we ask about symptoms, and those patients might not know any symptoms. So we talk about how they're feeling. There is a performance enhancing aspect to optimizing sex hormones. And, we're very remiss if we don't touch on that. But that's not the purpose for TRT and HRT. It's to optimize their health. So yes, affecting that body composition is a goal, because obviously we're going to, reduce obesity, heart disease. We're going to put that patient in a much better physical state. And obviously it helps, mental health as well. Just having the energy to get up and go and exercise and have the utilization of those coping mechanisms that we need for mental health. So it's definitely something that comes into play. We talk about it with the patients, how to improve their physique and utilizing hormones in that aspect. However, we definitely need to identify that patient has a deficiency, or in the very least is experiencing symptoms from a lower level of testosterone with maybe a low free testosterone. So they're not utilizing that very well. But sometimes we do have patients that, they have a testosterone level of, 500 or 600, and they're not having any negative symptoms. They're feeling fine. They're just hoping to look better. And there's some other means that we can utilize to improve their hormones. I'm sure you're aware, just weight-bearing exercises, talking to them about their nutrition, decreasing body fat naturally. Sometimes we'll use supplements like boron or L-carnitine that influence or affect their hormone production. But it's going to be very patient specific. And yes, sometimes we do put patients on therapy who do not have a clinical deficiency. We treat off-label with testosterone. But I generally won't treat the average person who comes to me just wanting to look better. There's lots of ways to do that if you have good testosterone production.
You provide all kinds of administrations, so pellets, transdermal and injectable.
We only do, go ahead, sorry.
So we do have transdermal. We use a compounding cream in those patients who are very.
This is bioidentical cream.
It is, yes, sir. It is. I prefer the injections. I feel like I have a little bit more control with adjusting those levels. You metabolize it a little bit differently than, with the cream. We're pretty much stuck with what we're using in terms of half-life. But we do have a couple options available. In my opinion, the pellets are variable. I've anecdotally seen really good stories, and I've seen really bad. So we don't offer that method, but I do talk about it with my patients.
Yeah, Ron used the pellets initially, and it was total disaster. Huh?
Dr. Abraham Morgenthaler was my I was lucky enough to have him as my physician for 2 or 3 years. And we started off with the pellets and they came out, they worked their way out of my glutes, even though they had been injected about that deep into the muscle. I was picking them out like little rice pellets.
Yes.
I have a question for both of you though, Andre and Dawn. I feel as if the term TRT has been sort of misappropriated and bastardized, where I have guys messaging me all the time saying, I'm on TRT and my TRT is a gram of test a week. 800 milligrams. It's become like almost interchangeable to a lot of people for a cycle, which obviously it's not.
No.
Do you have to educate people on this all the time?
Absolutely.
Oh, yeah.
I feel like most of my job is educating people. You know, it's important that I talk about their nutrition, their activity level, their social life. You know, are they having depression? Those kind of things are important to talk about. But the understanding that TRT is not steroid abuse or steroid misuse. We don't cycle TRT. We are replacing a deficiency in a patient. And so a lot of times I'll have patients who want to know, you know, if I get on a cycle, well, excuse me, that's not what we're going to do. You need to understand there's a difference between cycling hormones for whatever purpose and testosterone or hormone replacement therapy. The outcome ideally is that we have your hormones balanced and they maintain stable in that level where you feel your best and you perform your best and hopefully you look your best. But it's definitely a lot of misunderstanding, a lot of bro science. And although there's a lot of value in anecdotal evidence, you know, the scientific studies support TRT long-term for overall health, not cycles, and dosing is patient specific. You know, what one patient needs and what another needs are going to be very different based on their body chemistry, their genetics, their activity level. And so that's another thing that's very widely misunderstood is so-and-so takes X number of milligrams of this or that, and that's what he looks great doing that and feels great. That's what I should be on. Yeah. Well, that's just not how this works. You know, your body chemistry, your free test is very high. You have very low SHBG. You have very low proteins that are affecting your bioavailability. You probably will feel just as good with a total testosterone of 800 as somebody with a total testosterone of 1200 with a low free test. So it's very much about what your lab work for you specifically identifies your need is.
So what kind of esters you provide and what other compounds do you supplement along with testosterone?
So number one is nutrition. We talk a lot about understanding fats, good fats, bad fats, balanced diet, but we do a lot of recommendation for supplementation, you know, the basic amino acids, creatine in those patients who are trying to gain weight.
Is part of general overall anti-aging regimen.
Physique, yeah. So we generally start off with, you know, an intake, we go over lab work, we identify a need, and the goal, number one, is to balance those hormones. Once we have those hormones balanced, then we talk a little bit about those patients' goals. And often we'll see patients, you know, our combat veterans, we have a lot of stunt men, you know, who are very physically active, demanding on their body. They've got a lot of chronic joint discomfort, and they're using large amounts of NSAIDs and trying to get those joints to feel a little bit better. Sometimes we'll use a nandrolone decanate or nandrolone propionate for joint discomfort. We can safely use that as an adjunct.
It's off-label, obviously. It's off-label.
To TRT,
yeah. And so you provide cypionate, enanthate.
We carry a blend of a propionate, cypionate, and an anthate, very similar to like Sustanon. Generally, I don't use that in someone who's testosterone naive, but if someone is coming to me from another clinic, we're transferring care and they're doing well on that blend, I try to match that for the patient. Ideally, the average patient, we're using a cypionate, you know, moderate half-life, 2 to 3 times a week injections so we can keep them nice and balanced. If we're seeing a lot of, you know, side effects occurring, you know, patients who have that propensity to aromatize highly, or patients who are experiencing a lot of erythrocytosis. They're producing a lot of red blood cells.
Do you help people with phlebotomies? Do you provide phlebotomies?
We provide therapeutic phlebotomy prescriptions for patients who require it. My goal is to prevent the need for it if I can. We've found that
really relieving knowing that somebody who is willing to help me with phlebotomizing or blood donation, because you know it can become critical and many deny why it's high. And the classic excuse is I smoke, I snore, and I live in high altitude.
Yes.
But you need to get relief of the, you know, of this high viscosity. And I'm asking because it's really helps a lot to know that you can draw blood from a patient and waste it because he's in high production of erythrocytes. Now, what about DHEA, the HT cream? Do you have access in that? Pregnenolone, HCG, HGH. Do you have access to these compounds?
So most of that list you just mentioned, yes, we definitely try to preserve that feedback loop in patients who are maybe concerned with fertility, or patients who are younger, childbearing age, might tell me that they're finished with family planning, but they're 32, well, yeah, they're deficient.
Another thing about the control of estrogens, personally, I'm in favor of optimization of all hormones. So a little bit of aromatase inhibitor will be necessary if needed. Not to everybody, but there is a wave now from some guys out of the replacement therapy community that demonize aromatase inhibitors, and they tell that let the estrogens go sky high no matter what. And it's conflicting, and it's sad because I believe everything has to be in balance and optimized.
Yes. So I've done some research on kind of the method that they utilize. They feel like in a male, testosterone aromatizes to estradiol. Estradiol is an important hormone in the male body. So they feel like we shouldn't prevent that aromatization occurrence. We shouldn't block that enzyme. My goal is to educate my patients so they can make an informed decision for themselves. So we do talk about that. We do talk about the long-term risk of taking aromatase inhibitors. And ideally, if we can optimize a patient's hormones, get them feeling great, their levels where they should be and where they're in a safe range, without needing an aromatase inhibitor, obviously that's going to be a goal. But the reality is some patients aromatize very highly and at a lower level of testosterone. So in those cases, we talk with the patients about what their options are. We can lower the testosterone below that point at which they're highly aromatizing, or we can just deal with a higher estradiol level and make sure they're aware of what symptoms might occur. And usually that's the first step, is slightly lower the testosterone if we can. But we do need to treat those symptoms. If they're experiencing, major bloat or water retention, where they're uncomfortable, they're having major mood swings, they're emotional, they're having erection quality issues, we put them right back to where they started. So we're going to correct that.
You treat also women? You deal with women too?
We do, absolutely, yes. I'm on TRT myself. I'm 43.
But obviously progesterone, estrogen as well, huh?
As well. So I don't treat estradiol directly. Being in the TRT world, the telemedicine world, where I can't physically assess my patients, I don't treat females with estradiol. I'll refer that out to a GYN or someone who can do clinical breast exams and those kind of things. But I will, obviously we can increase estradiol with with testosterone. If they're deficient, we'll often see the estradiol improve. And in the progesterone, we treat with progesterone in females. We monitor all of the hormone levels, so if there's an area where they have a need, we address it. And if it's something that I can't provide, I at least give them options to how we can treat it or how they can get that treatment.
Dawn, I have to step in. This is I have to go back to the subject of esters because there was a little bit of I wouldn't say controversy, but Johnny Jackson has a podcast, I believe, and he was talking about, he's a patient of Frontline, and he was talking about one of the things that you had done for him was advise him to use, or these were his words. I'm paraphrasing.
Yes.
I think he had been, whatever ester he had been using, you had advised him to use a different one because, he stated as an African-American man, he has a much higher risk or a higher risk of heart disease and high blood pressure, things like that. And he was of the belief that certain esters of testosterone would exacerbate that problem much worse than others. So you had switched up his esters, which I believe is technically medically inaccurate. And for whatever reason, those are the words that came out of his mouth, but people made reaction videos to it and they were appalled and shocked. And this is your chance to set the record straight. Do different esters of testosterone affect your blood pressure differently, or is all test eventually in the bloodstream work on the body the same way?
Exactly. So, ultimately raising testosterone level, regardless of what ester you're using, you still have the same risk. I think what's unfortunate is Johnny's intention was to educate, was to say that, I was doing things wrong for a very long time. And yes, I was able to be, at the pinnacle of my career, one of the best in the world, and still one of the best in the world with very little knowledge on my own of what I was doing. And he took on some risk. So he was trying to vocalize the fact that coming on board with Frontline, we did an extensive blood panel. We went over his lab work together. And I had identified that we should make some changes to the protocol that he was on because of his increased risk for heart disease as an African-American male. And the ester that we switched him to was a longer ester, yes, but the rationale for why I was changing the protocol to that ester more so was because I was breaking up his injections more frequently. Okay. And that was the effect on the blood pressure that we were talking about. He misunderstood in changing the entire protocol to every other day injection frequency with a longer ester. We were hoping to reduce that peak testosterone level from getting so high where he's experiencing hypertensive episodes. And we're maintaining his blood pressure in a healthy range now. So I feel like that was an opportunity for our community to acknowledge that there is some ignorance in hormone replacement therapy and steroid use and misunderstanding, and the importance of being guided by a medical professional. And that's really what he was talking about, but it kind of got misdirected and everyone was focused on the ester. The purpose really of that change to his protocol wasn't the ester specifically, it was changing the frequency. We just happened to change him to a longer ester. And he was, still taking the same weekly dose, but by breaking that dose up into every other day injections with a longer ester, there's one more carbon on that ester. So it's going to take a little bit longer to break down in the body. We're going to do more frequent, smaller injections. So the peak test level with each injection is lower. We're just taking every possible step we can to preserve that renal function as he gets older, prevent high blood pressure and things like that. And I think that although he maybe misspoke or was misunderstood, or, he didn't say it as eloquently as he should have, the goal of what he was trying to say was that people need to understand that you can't just do this on your own safely. You have to look at lab work, and different people are going to require different protocols. And that was really the purpose. And it's unfortunate because I feel like we had an opportunity there to build on that and to educate and to make something positive from it. And it turned into something negative. So it's unfortunate because Johnny's an amazing guy and he's a very smart guy. And they were kind of attacking they were attacking his knowledge, and that's unfortunate because the man's very smart.
So guys, what is the average age of a man that you treat? Is it early 30s, late 30s, early 40s, late 40s, 50s? What's the oldest patient you have treated and the youngest also?
That's funny. I actually at one point had talked with Andre and my peers about, my colleagues about, should we have a maximum age that we should treat patients, because the guidelines don't recommend a maximum age that we cut off. And so I did some research and I found nothing to support that I should have a maximum age.
Today I had a patient of 62 and he looked phenomenal. Of course, he had 350 testosterone. And I told him, if you manage to double your testosterone, you're going to be a Superman. But he was 62, so there's no limit to that. And also I had patients in their late 20s because they were party animals. They are doing narcotics, insomnia, lousy lifestyle, and they had a burnout, plus some steroid abuse in the past. And they became toasted just before the 30s, so one size does not fit all, everybody is different, No,
and we treat each patient individually. So yeah, a 25-year-old with a head injury, might have a testosterone level lower than mine. And how would I be serving him as a provider if I ignored that need and didn't help correct that imbalance so that he can feel like a whole man, so that he can have children as he gets older, not have depression, not have obesity. We have to address it. And every protocol is going to be specific to that patient's needs. So, a younger patient, we're going to use things like you said, HCG, the gonadotropins to preserve the feedback loop so that long-term, as best as possible, we can prevent that disruption of that feedback loop or further decline in their test level. But in most cases like that, like we're talking about the younger, 22, 23-year-old, they're already so low that, there's not a whole lot to preserve there.
Actually, the new generation is of low testosterone. We spoke that with Rick Collins, with Ron Harris. And the generation of our fathers had lower testosterone than our grandfathers. And so it goes on, So the new generation is of low testosterone, hypogonadic. And of course, it's this demonization of testosterone, criminalization of testosterone. And we're living in a world of high estrogens, which is hostile to the androgens, So I believe the lack of physical activity, too much of the internet, and lack of exercise, bad lifestyle, and bad eating habits of the new generation, plus some xenoestrogens, you know, and all these environmental factors contribute to hypergonadism and also low fertility in the new generation.
Absolutely.
Yeah, I mean, to address this, if you would, I'm really frightened for the future generation because there are all these chemicals. I can't recall the term for them.
Estrogens from the plastic bottles. Yeah.
Yeah, but it falls.
Phthalates and BPA.
Soy also.
Yeah, there's something that suppresses hormones or something, and they're in every.
Prolactin, stress, cortisol. Yeah.
They're in household items all over, plastic, all kinds of things, packaging.
Teflon.
They're all around us. That's so.
And if you look at what other countries allow in their products that people consume, their makeups, their shampoos, the foods, it's very different than what's allowed in the United States. And you have to think about what drives that. Well, money drives that. You know, those decisions come from legislation. Who lobbies legislation? People making money on those things like plastics, you know, petroleum that goes into plastics. You know, big pharma. You know, if everybody's fat and depressed, we're selling lots of medication.
I've said that testosterone ruins the sales of the big pharma because testosterone can replace statins, Viagra, SSRIs, you know, so it's not cool for a cheap drug that is less than $10 to
Disrupt.
Well,
to disrupt those big pharma medications that are overprescribed, you know.
Yeah, I mean, Don, erectile dysfunction drugs, billions and billions of dollars are spent on them every year. How much of that, take a wild guess, would be unnecessary if every man had optimal testosterone levels?
Oh my goodness. Yeah. So I have a lot of patients that come on board with a deficiency. And that's one of the first things they ask me. We're in that initial phase where we're just talking about what they need, what dose they need. We're going to order those meds and get them started and educating them on how to do their injections and whatnot. They're asking for a Cialis or Viagra or something of that effect to help with the erection quality. And so we'll start with it. You know, I will definitely order it for a patient who's feeling like they need that for their erection quality. But there's a large percentage, and I really don't want to just be subjective and throw a number out there, but a very large percentage, I will say, ends up no longer requiring those types of vasodilators. And you know, once the hormones are optimal and they're balanced and they're rocking and rolling, they're feeling great. They don't have those erection issues any longer. They also don't have the psychosomatic issues where, you know, they're not, there's a mental connection with erection quality. And that comes into play as well as they start to feel better. They start to have more energy. They start to have less depression. SSRIs affect erection quality. You know, a lot of our ED in this country is actually medication induced.
So Ron, one of our catchphrases is making morning wood great again.
Do you have is that a hat? Do you sell that as a hat?
I have the hat, yes. We have the hat, we have shirts. You know, it's been something very funny that we pitched to our patients. They've gotten a kick out of it. You know, Swole Mail was a message. It was me sending somebody a private message to let them know that I gave them information on whatever clinic it was that I was working with pricing, with the link to sign up and all that stuff. And it just spun like wildfire. Because in a group that I was working in, one of the admins didn't like me using the term DM sent or PM sent. So he made me change it. So I said, well, it makes you swole. It comes in the mail. And there was the birth of Swole Mail.
Okay. Yeah. Dr. George, further questions?
Now, this thing that you remind me, make our mornings great again, reminds me of a former president. That is yeah, that is actually, he was on testosterone, yes, so he was into replacement therapy. Yeah, he had shown his testosterone levels before the elections. So I believe, many world leaders like Berlusconi in Italy, or I guess, Donald Trump also, they're implementing. Actually, the first president who used HRT was Kennedy. He had an Addison's disease. He was taking injectable cortisone. That cortisone led him to osteoporosis, and then he had to use testosterone because also cortisone antagonized testosterone. And he became so sexually aroused with testosterone, he was unfaithful to Jackie. But he was using the first man who was using cocktail hormones. Yeah.
Hey, that's something too. You monitor, Don, you monitor these levels, your patients very carefully. Yes. Do you get to the point with some gentlemen where, you know, you have to cut back on the doses, I imagine, if their levels are getting too high, or would they?
Sure. Yeah, I mean, we have to start somewhere, right? We don't know what everyone needs. So we follow evidence-based practice, on average, what do most males require? Testosterone dosing. We do our initial follow-up labs about 8 to 10 weeks after initiating therapy. And at that time, we can kind of identify, if we need to make a change to that dosing. And so I have patients that are doing fantastic on, 70 milligrams a week of testosterone. That's all they require. They feel great. And then we have someone, 300 because they require a higher dose. And that technically is a very high dose of testosterone. But those patients, may have lived at a much higher level for a long time. They've abused steroids in the past. They're not producing much endogenous testosterone on their own.
Yeah.
Their free testosterone is lower. And I need to get their testosterone at 1,000 or 1,100 for them to feel well. And so we do follow up at that 8 to 10 week period. And then every 6 months after that, the guidelines from the Urological Association recommend every 6 months to a year doing specific labs. So we're looking at things like, PSA. Is there any concern that this patient might have prostate cancer? Because we wouldn't want to give them testosterone if they had prostate cancer. It might exacerbate the situation.
Sure.
We're looking at their cholesterol levels. We do nutritional counseling. We might need to supplement with, a high quality fish oil or whatever their body needs. Teach them about eating more fiber. We'll look at, obviously CBC, CMP are important for looking at the viscosity of their blood because we can see some erythrocytosis with exogenous testosterone administration. We'll look at the kidney function and liver function. A lot of times my patients are trying to change their physique once they start feeling better. They're trying to get into better health. So they'll start using a lot of supplements, and in small amounts, those fillers that are in supplements are benign, but in large amounts, sometimes even vitamin C powder can cause some inflammation in the liver. So we're looking at a lot of things on their panels, not just testosterone and estradiol. And it's important to do that follow-up, and we will decrease the level or a dose if we need to. And if we need to adjust the frequency of dosing, micro dosing or even every other day dosing, that tends to help prevent with those side effects. So this is why we try to impress on patients that we have to kind of figure you out. That's what this process is about, is determining what you need and what makes you feel your best. And that's very different than anybody else. So we have to do that lab work. You have to follow up, like I tell you, because I can't get you to that point without that follow-up. So it's important that they do their lab work as well.
Yeah. I mean, your clinic, Dr. O'Connor has been very vocal that there are a lot of TRT clinics. The vast majority of TRT clinics, and we use that term loosely, they don't do this type of follow-up. They don't talk to you about nutrition. I think they just take your money once and they just keep refilling your prescriptions. And there's nothing like what you're doing. Do you have to deal with a lot of the general public's perception, maybe the medical community's perception, that TRT clinics are all a sham and they don't?
Sure.
Yeah.
Oh, sure. It's the Wild West in the United States with TRT clinics. I mean, there's really not a whole lot of guidance. It's a lot of selling products, a lot of compounded amino acids and things like that they have a great purpose. But my goal is to keep that patient as healthy for as long as possible. Yeah, changing their body composition, helping them lean out is part of that. But number one, it's their overall health. And sometimes that means spending 30 minutes teaching them what macronutrients they should be eating, how often they should be eating. People they just don't know sometimes, and they think they're doing the right thing. They don't realize what they're doing isn't the best for them. And it needs to be kind of a holistic, almost a functional medicine approach with TRT. And because it's a moneymaker, I believe that there's a lot of clinics out there that are turning out a basic protocol for everyone, stamping or checking boxes. And we end up getting those patients because they end up not feeling well. They're having ED issues. They're breaking out with acne everywhere. They just don't understand why they feel like they're on a roller coaster. And we end up getting those patients. And I see it. I see the good and the bad. That's not to say there's not some great providers out here doing TRT. I have some colleagues that I rely on heavily when I feel like I need some help. And I feel like we have a good core group of providers in the US right now that are doing it the right way. And hopefully that continues. I think we touched on this a little bit at the Arnold Education Seminar, is the increased incidence of hormone use in treating gender dysphoria, or whatever it's called today, patients who are transgender and they're changing their hormone balance for that purpose. And I think that's going to ultimately end up opening some doors for TRT and HRT management of the average patient as well. because we all need to have optimal hormone health.
So you guys provide telemedicine across the state, or is it just face-to-face in your clinic? The consultation?
Telemedicine.
We're telemedicine. We do a lot of this, a lot of video conferencing with patients,
Right.
telephone calls with patients.
And you prescribe across the states, huh?
We do. We're nationwide. We also, you know, our medicine model is kind of a concierge model. You know, our patients do not pay a penny for their consultation. So as often as they need us, we're there. They schedule appointments and we do consultations for them. So
Yeah.
Yep. I tell them it's 1 or 50, whatever it takes to make you feel comfortable with what you're doing.
And in some cases, that's a video consult like this, where I'm actually walking them through the process of how to mix their gonadotropin.
You mail the medication, huh? Through the mail.
The pharmacy mails them. We don't. Those pharmacies that are licensed in those states.
Okay.
Yeah, I send the order to our compounding pharmacy. They make the medication at the specifications that I give them, and then they ship it directly to the patient with everything that they need to administer that protocol. And then we educate them on how they're going to do that, and we do the follow-up with them. So the patients actually administer the medication themselves. And that's why it's important to have options, you know, because some patients aren't comfortable with the idea of giving themselves an injection. So we use other options, but sometimes it's just a matter of teaching them and helping them, giving them the tools that they need to be independent. And we get a lot of patients from clinics that require them to come in once a week for an injection, and it's a cost and it's time consuming. And we give them a little bit more autonomy in managing their care on their own, with our guidance, of course.
So how can prospective patients reach Frontline Alternative Medicine?
They can reach us at our website at frontlinealternative.com. That's the easiest way. We're also on a group called Planet TRT and HGH Support. It's a group where they don't need to be our patients to be in the group, and we just try to share information in there. Facebook group.
Facebook, yeah.
Mm-hmm.
Okay.
And then I have an Instagram. It's Swolemail, at Swolemail. It's SLWLEMAIL, and I that'll provide links to that group also.
Great. All right.
One of the reasons why we started looking at the bodybuilding, I started to interrupt, Ron, but I wanted to talk about us at shows and being at shows and traveling to events and things like that. I get looked down upon by some of the HRT groups because I'm helping bodybuilders.
Yeah.
We're reaching out to the bodybuilding community to help save lives. We saw a huge increase in deaths, and our big thing is, I mean, you know, get your labs with us, do your basic protocol with us, so that at least we can give you some heads up when something's going on.
Reduction, yes.
Okay.
Absolutely.
All right. Dr. George, any closing thoughts, Dr. George?
Yeah, I want to encourage Andrea and Don what they're doing to keep doing and spread the knowledge, you know, because we need more people who believe in the replacement therapy to make others also believe in this replacement therapy that is actually a full-time and a lifetime treatment to a disease that has no cure, and bring health and happiness to hypogonadic men and give them a second chance for a second puberty.
Great.
And we age because our hormones decline. So I want to thank you again for accepting my invitation to be my guest. And I know that you cooperate with many people from the bodybuilding community. This is good because, unfortunately, the vast majority of retired bodybuilders are facing the anabolic steroid-induced hypogonadism. And I hope to see you this year again at the Olympia.
Yes.
Oh, we will. We're already planning for it. And you know, one other thing is that, you know, one of the things that sets us apart from every other clinic is that my wife and son and I drive around the country and go visit our patients, take pictures with them, give them shirts. We've visited, I want to say, close to 32 states in the last year.
Oh. Wow. Okay. Well, that's a wrap, guys. We appreciate you coming on the show so much. Very informative. If any of you out there are in the need or think you might possibly be deficient in testosterone and want to do it the right way and be fully supervised by professionals, frontlinealternative.com is there for you. And we appreciate you watching the show. Please subscribe to the channel, like the video, share it, comment on it, do all that good stuff, please. And we'll see you next time right here on Ask Dr. Testosterone. Thanks for watching.